hemorrhagic events. The 150 BID has a superior efficacy with similar bleeding risk than warfarin, so it's more efficacious, no increase in bleeding here. 110 milligrams has basically significantly less bleeding with similar efficacy. It's as good as warfarin, and actually the bleeding risks are much better. So let me end by giving you a little bit of a case study. So this is a 66-year-old woman diagnosed with AF, chronic AF, 6 months ago, mild mitral regurgitation, hypertensive for 2 years, hypercholesterolemia. Number one, first decide, does she need basically an oral anticoagulation or not? So our guideline is a CHADS S2 score. So if you look at it, these are our family history, these are our medicines. So physical examination, again, nothing very abnormal. Now, we need to have an evaluation. So actually the CHADS S2 score is just one. If you look at the CHADS S2 score, there's only one here, okay? But if you do the final adjustment that she is a lady with mild mitral regurgitation, and she's a lady in the 64-75, the CHADS S2 score becomes slightly higher, and instead of just aspirin, you would require an oral anticoagulation. So this is where we had done, okay, her CHADS S2 score was less than 2, but she had a female sex and the age group was more than 65. So the minor risk factor, you had more than 2 minor risk factors in this case, your decision is then an oral anticoagulation. So basically, we would then ask, why should we matter? What should we do? Obviously, the choice would be dabigatran, but let us next go to the next stage. What would be the dose of dabigatran used in this patient? We need to do renal function, switching, mild mitral regurgitation, concomitant medication. So the renal function must be assessed when you start. If your GFR is above 50 ml, then you can use the higher dose of dabigatran. So 50 ml, creatinine clearance greater than 50 ml per minute, there's no dose modification necessary. On the other hand, if your GFR shows moderate impairment, then you would actually reduce the dose to 110 milligrams. And dabigatran is contraindicated in severe renal failure, that is GFR of 30. So this is the only precaution we need to do. Furthermore, these are cardiac patients and their renal functions deteriorate from time to time. If you look at the whole cardiac, you're using diuretics, you're using ACE inhibitors, and their renal functions deteriorate. So if you're using dabigatran, please check the creatinine from time to time, maybe 3 to 4 months onwards. You need to check your renal function because you might need a dose modification. Other thing, people who are on warfarin and you want to switch them to dabigatran. So what is? Do you use the two molecules together? You stop warfarin. And the moment INR falls below 2, introduce the dabigatran dose. Let me tell you another very important advantage is it is a short-acting molecule. So suppose you have an oral anticoagulation on a patient and he requires an emergency surgery, say he comes with basically a perforated pelvic ulcer. In warfarin, what do you have to do? You have to stop the warfarin. His INR, if you leave it like that, is not going to come down in 24 hours. It's going to take 2 to 3 days for the INR to come. So you have to use FFP to revert it, or you have to actually use a vitamin K to revert it, preferably an FFP. In dabigatran, on the other hand, because it's a short-acting molecule, if you miss just the evening dose, he will be ready for surgery the next day. So that's an additional advantage. So I think what we, the valvular disease, I think we have I will just show you the recommendation, sorry. The recommendation now which has come up in the European guidelines. So these are the American College of Physicians guidelines where they have now considered dabigatran rather than dose adjusted PK. This is vitamin K antagonist. So it is already in atrial fibrillation, chronic atrial fibrillation, the choice of oral anticoagulation is now coming to dabigatran. The reason being of those phenomena. It's easy to use, predictable dosing, less drug interaction, and the moment you take them off, you're ready for the surgery or an intervention the next day. So I will not go on to the others. So we will say thank you, and if I will take any questions or queries if you really have some.